This is week 5, video 2 on the United States healthcare system, part 2. Long-term care. The policies related to reform in long-term care are listed on this slide. Just a little background. When I often talk about when I was in school, but I can remember doing my rotation in a nursing home. There were no rules. People were just sat in jerry chairs and lined up in hallways. There was no stimulation, no activities. They were put in front of a TV sometimes, or just in the hallways if they had dementia and they didn't think they would watch TV. People were just laying in their bed. There were no rules, and long-term care needed to be reformed. I think we may have gone overboard because they say that long-term care in this country is more regulated than the nuclear power industry, which says a lot. And some of you probably have worked in long-term care, and there are a lot of rules to follow and a lot of agencies that come and look at what you're doing to make sure that your care you provide is of high quality, or at least of minimum quality, I should say. So long-term care reform in 1990, the American with Disabilities Act was passed. And although it wasn't really focused on long-term care, it did have a significant impact on people with disabilities, including those who need long-term care. The long-term care facility cannot discriminate against you based on disability, and it increased accessibility of all public spaces and facilities. Omnibus Budget Reconciliation Act, OBRA of 1987. This is the big thing where people realized that long-term care needed to be regulated in this country because of the substandard care that was being provided in many areas. So this is the legislation that made those changes to nursing home regulation, put those regulations in place. They set minimum standards if a nursing home wanted to participate in Medicare and Medicaid and Medicare programs. This is where the residents' rights, the quality of care, quality of life standards were put into place. The Balanced Budget Act of 1997 had implications for long-term care. This introduced the Medicaid state plan personal care option, where people on Medicaid were given an option. Instead of going to a long-term care facility, they added in-home and community-based settings to be an alternative to institutional care. And there were centers open. I know there was one in Norwood that I'm not sure if it's still there, where it was like adult daycare, but it also had the physician came there to see you when it was time. Any therapies came there to see you, and you were taken care of during the day in a place, but you went home with your family in the evening. The Medicaid managed long-term services and supports. Because of, wanting to manage Medicaid funds appropriately, many states have moved to having a managed care model for Medicaid, including managed long-term care service and supports. They're trying to make sure that care has improved coordination and is more cost-effective. And they also try to push home and community-based services over institutional care, because it really does cost less if you can manage people at home or in a community-based setting. And in the Affordable Care Act in 2010, it included provisions in enhancing and expanding long-term care services, and increased funding for the community first choice option that encourages states to have alternatives to institutionalized long-term care and move towards home or community-based services. Chronic care management programs. A lot of policies and initiatives focused on improving the coordination of care for individuals with chronic conditions, and that enhances quality of care, prevents unnecessary hospitalizations, and that's particularly relevant for the long-term care population. They don't do well when they have to move from the long-term care setting to the hospital and back. PACE, those are programs for all-inclusive care for the elderly. That integrates medical care, long-term care, and social services for frail people over age 55 and older that qualify for Medicaid, and it allows them to receive care in the community and promote aging in place. State interventions. Many states have innovative programs to expand home and community-based services, which is the HCBS there. It wants to give people more option and try to avoid folks having to go to a nursing home, because life in a nursing home, although some are very nice, being independent, especially in our society where independence and individuality is so important, having care provided where you can age in place is extremely important to individuals. Dual eligible integration initiatives. This is where they've tried to integrate care for people who are eligible for both Medicaid and Medicare. And this is to improve the care coordination, and because these people have complex care needs. And then Veterans Directive programs, they are trying to allow veterans to self-direct their long-term care services rather than just use a VA nursing home, and having them have more control and flexibility in their care. What's the role of long-term care reform? The role of long-term care is addressing chronic conditions. They can diabetes, heart disease, etc. They require ongoing management. That long-term care doesn't necessarily mean long-term care as being institutionalized. It's not acute care. It's care that's being provided to you over time to improve your health outcomes. We want to support aging in place. That is so important. And we want to try to prevent unnecessary institutionalization, which greatly impacts the quality of life of our senior population. Preventing hospital readmissions, not just for people in nursing homes, but for people with chronic conditions, keeping them out of the hospital and as healthy and experience the greatest quality of life as possible. Improve care coordination, and increased family caregiver support and education. And that includes respite care. When you think about families that are caring for folks in the home, even if they do have some community services, respite care is important, because I've known families, because my specialty is gerontology, actually, one of my specialties. I've known families who haven't had vacations in 10 years with their children. Their children have grown up never being able to go on vacation because they can't leave their parent. And having some kind of respite care and support will allow them to still be able to have quality of life themselves, while also providing quality of life for their parent. Promoting independence. we're not looking at long-term care just as putting people into nursing homes. Long-term care focuses on enhancing independence and trying to help people either improve their functional abilities or provide ways for them to have their activities of daily living met. Those might be assistive technologies. They might be having a care provider available for some things, but promoting that independence as much as possible. Looking at health holistically, not just addressing medical needs, but the social needs, the emotional needs, psychological aspects of well-being. Looking at the person as a whole improves outcomes. And it's what most of the initiatives we see are focused on, these things. Managing complex health needs, making sure that if people have chronic illnesses, therapies, wound cares, problems with their medications, that their health needs are met. Preventative services, minimizing the risk of deterioration of health and independence by making sure people are have regular physicals, education, information on healthy lifestyle choices, vaccinations for things like shingles and pneumonia, which can cause illness, which can take away in an older individual's ability, or somebody with chronic illnesses ability to live independently. And then economic considerations, trying to manage healthcare costs by having the least costly options available and alternatives to institutional care, such as the home and community-based services. That not only helps people's quality of life, but it also improves hospital and healthcare system sustainability, their bottom line, their revenue and expense streams. This is just some information on, we're moving now from long-term care to a new thing called the retail health center, or retail health provision, and this is where health services are provided in grocery stores and pharmacies rather than in doctor's offices and hospitals and urgent care centers. And they're projected to grow, and that's what this information talks about here. And we're going to just talk about this a little bit. When you think about it, I had a really, really bad cold that I thought might be COVID right before the semester started, and I couldn't get into my doctor's office. There was no appointments. So I actually went to Kroger's, the little clinic at Kroger's, to get checked to make sure I didn't have COVID or the flu, and I didn't. It was just a really bad cold. But if people can't get into their provider, or they don't have a primary care provider, these retail health clinics are an option that people are using in an increasing manner. The key players in the report that I just was mentioned on the previous slides, it shows here, these are, CVS, Walmart, Walgreens, Kroger's. These are big Target. These are big providers in the retail health services business. The big things that they treat in retail clinics are acute respiratory infections, sore throat, conjunctivitis, pink eye, UTIs, providing immunization, screening services, particularly for people who need something done before they can, say, start nursing school and can't get into doctor, they might have a quick physical done at a retail health clinic. And it's an immunization has been the largest share in the market in it held in 22 because people want to go there to get their flu shots. And when COVID shots were huge, that is one of the places people were going. The big advantage is convenient. They're in place that are very accessible. They have lots of walk-in options and can see people quickly. They have usually have extended hours. They're open longer than a physician's office may be. They're open on weekends, giving more options for people to receive care. As I said, there are walk-ins. You're treated very promptly. You don't have to wait for an appointment as much because there's not emergency health issues served in these clinics. The pricing is transparent. You have a sheet. It has fixed prices, and most of your insurance companies will allow you to use your insurance there because it actually can be less expensive for them. There are basic primary care services, minor illnesses, vaccinations, preventative care. So common healthcare needs can be treated there. They do point of care testing, like testing for strep throat, flu, COVID, etc. The pharmacy is generally right there so that you can get your prescription filled immediately. And there are some telehealth options at some of these clinics. The disadvantages is, as we said, there is a limited scope of services. They might not have all of the comprehensive care needed for somebody with some chronic illnesses. It's not a substitute for emergency care. If you have an emergency, you shouldn't be using a clinic. Continuity of care, they might not be hooked into your MyChart or your Epic systems in your hospital. So there's not the same level of care coordination. That it depends. Some insurance will cover it, others will not. So you need to know that before, if you have insurance coverage, you need to know if it's going to be okay to go there before you go. And then that's the same with continuity of care. There may be fragmented care because they're not, the health records aren't shared. There's limited communication between your primary care provider or other specialist or the hospital system where you might be admitted in the future. It should not replace primary care. These people are not seeing you on an ongoing basis, providing comprehensive care to ensure that all your health care holistically needs are met. There's not really provider continuity. The staffing model, there's lots of different advanced practice nurse generally. Occasionally there'll be physicians, but they work shifts, so there's not that continuity of care. You don't necessarily see the same person. There's an over-reliance on antibiotics. There's been studies that say that these retail health settings, if you have a respiratory infection, they're afraid of missing something, so they will prescribe an antibiotic when one might not be necessary. There are privacy concerns because they're in open spaces and people can see that you're at the clinic. And then they don't really have specialty services at these sites. Policy considerations. When we think about the scope of services and regulation, there needs to be regulation on these centers. They should not be run willy-nilly. When you think about hospitals and long-term care settings, etc., even home care, they are regulated. There are agencies, whether it be the Joint Commission whether it be the state coming in, the Medicaid from the state coming in and surveying nursing homes. There are regulations and there's oversight, and we need to ensure that there is that same oversight and regulation of the scope of services provided, with clear guidelines on what these folks working in these places providing care can and cannot provide in relations to patient care. Licensure and credentialing. When you work for a health system, there is credentialing that's done if you're going to be prescribing or providing primary care, whether you be a doctor, advanced practice nurse, or physician assistants. Ensuring there needs to be policies in place for these health centers to ensure not only that people are credentialed, but that their providers meet established standards. It's a good idea that if we're going to have policies surrounding retail health clinics, that we require some sort of collaboration with traditional healthcare systems, so that if something arises, that you can transfer people to that acute care setting or wherever is needed quickly and efficiently. And for that charting piece, that the traditional healthcare system has access to the electronic health records from the retail health clinic. And then any regulations related to telehealth provided by retail health centers, they have to be they should be subject to specific regulations to ensure that they meet the same standards as when physicians groups, or which include generally physicians, assistants, advanced practice nurses. There's definitely guidelines. We need to make sure that any telehealth has specific regulations, because telehealth is growing so much, especially since the pandemic. And then reimbursement models. Policy makers can play a role in determining how retail health centers are reimbursed by Medicare, Medicaid, insurance companies, and etc. Insurance coverage policies should address how insurance coverage for these services will be maintained. Clear guidelines need to be in place there needs to be regulations saying that clear guidelines are in place, so people know the extent of the coverage at these places and what their out-of-pocket costs will be. Quality and safety standards, establishing and enforcing quality standards for retail health centers, just as they do for any health center. The health information exchange, I think we need policies to improve the integration of patient health information from the health center to the health systems. Policies should address continuity of care, ways to foster communication and information sharing between the health center and the primary care provider, and then ensuring patient privacy and consent, especially in such a open area, since they are different than the privacy that can be maintained in a traditional healthcare setting. Public health initiatives. I think policymakers need to consider how retail health centers can contribute to public health initiatives, such as when we have health screening campaigns, vaccination campaigns, and ways to improve the overall health of the community rather than just being a standalone entity. Workforce issues. There should be policies related to staffing ratio, scope of practice, and requirements of training to provide the care that's provided. Health equity. I think policymakers need to consider how retail health centers can contribute to health equity by ensuring access to care for underserved populations and potentially dealing with disparities in delivery, providing another point of access for folks who might not have the same access as the highly insured. And then emergency care coordination. They should clarify the role of retail health centers in what happens when something arises. There need to be protocols that if you get somebody and they need to be going to the hospital as quickly as possible, that's done appropriately and quickly. I think as the healthcare centers continue to evolve, we're going to need more oversight. I hate to say, things need to be regulated, but they do, because they are like a little island out there. I think they have great potential for very limited scope of practice. They can be very good at what they do, and we have to find ways to continue to coordinate the entire healthcare system, and policies and laws and regulations should focus on continued maximizing the amount of money that is spent on providing healthcare, and this can be a key piece of that. Thanks, and have a great day.